It's now my pleasure to introduce today's presenter, Dr. Kathryn McCans. Dr. McCans is an Associate Professor of Emergency Medicine and Assistant Professor of Pediatrics at Cooper Medical School of Rowan University. She is a child abuse pediatrician and pediatric emergency medical physician at the Children's Regional Hospital at Cooper University Medical Center and collaborates with the CARES Institute. A graduate of Temple University School of Medicine, she completed her pediatric residency at St. Christopher's Hospital for Children in Philadelphia and was also a pediatric emergency medicine fellow at St. Christopher's Hospital for Children. Dr. McCans is board certified in pediatrics, pediatric emergency medicine, and child abuse pediatrics. Now, without further delay, let me turn the webinar over to Dr. McCans.
Good afternoon, and thank you everyone for attending today. Today we are going to talk about abusive head trauma. I want to go over some goals. I have a little technical trouble. It's not advancing. There we go. So our goals are really to review the basic statistics surrounding abusive head trauma, to review potential findings on history, physical, or diagnostic studies, and to emphasize the pediatrician's role in the recognition of abusive head trauma. This is a topic that's very important to me. As we admit a number of children each year at Cooper, and you often feel that these might be preventable occurrences for these children. Abusive head trauma is a common issue. At least 1,200 children are injured each year in the United States, and there's approximately 80 deaths per year due to abusive head trauma. 30 infants per 100,000 children will experience abusive head trauma in the first year of life. And in a recent study in December of 2014 by Miller, published in Pediatrics, they did an assessment that recognized that potentially 339 U.S. children died due to abusive head trauma over the period of time of their study. And one of the things that we found as we follow these children is that nearly all children will have some sort of long-term disability. Even those that we thought had a relatively mild abusive head trauma, by the time they get to school age, we recognize that they have increased needs or require extra assistance to do well in school. So it's an issue that, because it is something that's not necessary or it's preventable in many ways, has significant effects long-term for both the children and for our providing of children care in pediatrics. The head injuries that can be encompassed by abusive head trauma are anything from the subdural hematomas, which are sometimes quite small, cerebral contusions or subarachnoid hemorrhages, diffuse axonal injuries, cerebral edema, anoxic brain injuries, skull fractures, scalp swelling, hematomas, and hair loss. So it really runs the gamut from soft tissue and superficial injury all the way to deep parenchymal injury. Many of us will recognize that we've learned in the past about the associated injuries that are present. Retinal hemorrhages are seen in a certain percentage of children, but most children, the most common associated injury is just bruises to the face or scalp. We also will see associated fractures, such as rib fractures, in particular posterior rib fractures, or long bone fractures like new fractures, healing fractures, or classic metaphyseal fractures, or associated skull fractures. However, none of these associated injuries are required for the diagnosis of abusive head trauma. In those cases where we only have intracranial injuries without associated injuries, can be quite difficult to work through as a child abuse pediatrician and to meet the standards necessary if we get into the legal ramifications of abusive head trauma. But it's still important for us to recognize the risk that that child with an intracranial injury is at, and at a minimum to provide services through child protection to try and change the dynamic within the family and make for a safer, healthier family, and thereby assisting the child. we do know from historical studies that inflicted injuries, particularly head injuries, are frequently missed. 3 significant articles, now getting a little bit older, but I don't think these things, the incidences have really changed. In 1999, published by Jenny and Emil, there was a study that really showed children who were admitted for abusive head injury, and when they looked backwards in their medical record, these children had been seen in the majority of cases for subtle but related findings, vomiting, irritability that seemed to resolve, or decreased feeding. And therefore, there may have been a missed opportunity before the injury was devastating to recognize what the child was at risk for. Additional article in 2003 looked at an at-risk population of children that were getting skeletal surveys. So there was clearly a concern for abusive head trauma in these children. And they had experienced pediatricians doing a complete physical exam. And despite being deemed a normal neurologic exam, the CAT scans showed in 30% of the children abusive head trauma that wasn't really expected based on the physical exam. And then a similar study in 2004 kind of, again, verified that even when we may not clinically suspect a neurologic injury, when children have been identified and are looked into, we frequently find findings on CAT scan and or MRI that weren't expected. Keenan and Runyon in 2004 published a study where there was comparison of inflicted versus non-inflicted traumatic brain injury, looking at their clinical features and outcomes as well as their chief complaints. And for children who were asymptomatic at presentation and had a specific history provided, a high percentage of those children had accidental traumatic brain injury. For those that had subdural hemorrhages, retinal hemorrhages, and classic metaphyseal lesions, those children at an increased number had inflicted traumatic brain injury. Or those children that didn't have a specific history were much increased to have an inflicted traumatic brain injury. So we know that as pediatricians, it's quite difficult sometimes to determine which children we need to really pursue testing on, and which may have a benign underlying problem. Certainly, as someone who is working in a pediatric emergency department, I get a little nervous when the child's come in with some vomiting and looks great for us, and it's particularly those children under 6 months and up to a year of age. Is this a child that we need to worry about? It can be quite difficult to find this injury early, but that's really our ultimate goal, is to miss as few cases as possible. We all need to be aware of the presence of sentinel injuries. This is the point at which we want to find child abuse in young children prior to have sustaining abusive head trauma. And sentinel injury is essentially a minor injury that, by recognition of its importance, might allow us to make an intervention and, again, make the family more safer, engage the family in services so that we can avoid future harm. And this is a difficult thing to prove clearly, because if you make the intervention and successful, we'll never see the abusive head trauma. We again know there are cases where that have been presented in the literature that when we look backwards in kids' charts, we find minor injuries that might have been a marker for us to begin an investigation or provide services to prevent future injury. One example, which was recently evaluated through the CARES Institute, was a 4-month-old child who presented to the emergency department with oral bleeding to an outside hospital. This was diagnosed in an emergency department as a mucocele when it was actually a lingular frenulum tear. This infant died at 6 months of age, 2 months after that presentation in the emergency department, due to a devastating head injury. There is a common saying that was promoted by Naomi Sugar, a well-respected child abuse pediatrician, that if you don't cruise, you don't bruise. If we can recognize injuries when they're minor soft tissue bruises at an unexpected age in a young infant where a child is not yet cruising, or a minor oral injury, then again, make the diagnosis that this is a very concerning finding and hopefully put in supports. We hopefully can prevent those misdiagnosed abusive head trauma or intervene or make the diagnosis early before we see neurologic devastation. We have to remember that when we develop a concern for abuse, there is a standard for us reporting child abuse to Child Protective Services, which in New Jersey is the number is 1877 NJ Abuse. And the standard to report abuse is that you are concerned that this child has suffered from child abuse or is at risk to be abused. You don't need to be definitive in your diagnosis. Often, when that call is made, there will still be a differential that's present. And even in admitted children, sometimes the differential concerns we're thinking about may proceed or continue to be persistent in our medical decision-making for days, depending on which constellation of findings we have. However, abusive head trauma is really much more common than many of the diagnoses that might be considered. Galactic acidemia type 1 is not a very common genetic disorder. It is in the differential for a child to develop subdurals of an enlarged head, and we sometimes think of that, things like osteogenesis imperfecta or an AVM or other venous malformation, a bleeding disorder, hypercoagulable or hypocoagulable state, all are things we may be considering and may take days to get the appropriate lab tests done. But in the end, abusive head trauma as a diagnosis is a much more common finding than most of the things we're considering. And therefore, it's important that we make a report early, because by making our report before we necessarily definitive our diagnosis, we may prevent additional injury. If a child has subtle fractures and you're considering osteogenesis imperfecta, as a pediatrician in the ER in particular, I never really know for sure the social situation at home, and I can't verify it easily. And our child protection colleagues can certainly work with us to look at the whole picture for this child and family as to what their risk factors are. It is always important, particularly in an office setting, when we raise the concerns for abuse, to ensure appropriate evaluation for the child. And I would really strongly urge those in office practice, particularly off-site from a hospital where you could easily walk a child to the emergency department for further care, that you consider 911 transfer. It is really upsetting to both the pediatricians as well as the ED provider when we get a call saying that someone's coming to the ER for this concern, and it takes hours for what should be a brief transport to the hospital. And really the only way we as providers have the ability to ensure that the child gets the care is really to employ a professional transfer service. Again, it provides great consternation and concern for the general pediatricians who I speak to in my role in the ER, as well as anxiety for me as to where is this child and why have they not yet come. Is this a family that's going to try and sort of avoid care because someone has raised a concern for abuse? Is this a child who has gotten worse, has been waylaid somewhere? It really is a difficult situation that I've seen happen fairly frequently when we don't ensure transfer to emergency further care. As I already alluded to, the presentation for abusive head trauma really has quite a spectrum in how it presents. Very subtle findings, such as a single episode of vomiting that seems to have resolved after or during evaluation, or an acute life-threatening event, which, no matter what the ultimate diagnosis as the cause for an ALT, almost always the children look great in our presence. And so this is one subtle finding for abuse that we must consider in our differential for its cause. There are intermediate levels of presentation which might have alternative explanations, scalp swelling or bruises on the scalp or face. Really, we have to evaluate in the context of the history. Is there a known small household fall, and is this a parietal swelling, or is this a bruise on the forehead in a child who's recently learned to pull to stand versus a young infant who is not yet mobile at all. And then there are the overt cases of abusive head trauma that I think we all early in the presentation consider as a possibility. Those children who present in extremis or in cardiac arrest without history, child who presents in coma or in status epilepticus with ongoing seizures. I think all of us, we don't fail to ensure care, to do imaging, to come up with a diagnosis when the symptoms are severe. And it is in the intermediate presentation or the subtle symptoms that we really have a great ability to improve our diagnostic acumen, our suspicion level based on a good history and physical exam, and proceed when we're concerned. It's important to really remember that when we obtain our history, we really want to do an open-ended history. And certainly in the emergency department, we are often at fault for not really asking that open-ended question. And I was recently at a lecture by a really well-respected child abuse pediatrician and pediatric emergency physician, Mary Clyde Pierce. And she made a wonderful had a wonderful discussion of, we sometimes wanting the symptoms to be from a benign cause, we might sort of use an assumed history or provide information to the family that allows them to give us the information we're looking for. Sort of an unrelated example of that, and very recently I was asked to review a case where there was concern that an emergency department had missed a case of child sexual abuse based on the fact that a young child, a toddler, had presented with some vaginal bleeding. And in the history in the emergency department, there was no history of trauma, and that was clearly stated. But there was history that the child had ridden her bike that day. And in the final assessment, despite the fact that there was some minor genital injuries noted, child abuse was not considered because they felt that, well, this is maybe a trauma from the bicycle riding, and yet there was no actual history of a straddle injury while riding the bike, no instance of the child starting to cry or falling off the bike, just sort of we have an injury that could be a straddle injury, and yes, she was riding her bike today. That's the sort of assumed history that we really want to avoid when we're seeing children by being open-ended, basically asking the family, what are your concerns? What are your thoughts regarding the symptoms? When did it start? Who was present at the onset of symptoms? Were there any other people present at the time, particularly if there's a proposed fall, such as a fall down steps or fall off furniture? If there is a fall described in our history, what was the height of the fall? What was the landing surface? What happened immediately after the fall? What care was sought? What were the child's symptoms? It is also helpful to get a social history to understand whether there's been prior child protection concerns or a history of domestic violence or criminal involvement, because these social factors significantly increase the risk for that child. But certainly such information is not diagnostic. It can only help us weigh, along with the rest of our history, whether we've reached our threshold to be concerned for this child based on the symptoms, the history we have obtained, and the social circumstances for this child. We also want to get a good developmental history at the time of the injury, and we need to think about, is this history consistent with this child's developmental history? Are we being told a very young infant rolled from the middle of a king-size bed, or that a toddler who is just starting to pull to a stand climbed out of their crib? How much can we verify as to this child's ability? Is it consistent, or is there variances that result in concern? We also would like to know if there's any past medical history or family history that will tell us about underlying conditions or risks that would alter our assessment. Certainly in the child that there's a known family history of osteogenesis imperfecta would be viewed differently with fractures than a family in which there's no history of multiple fractures. So too, if there's a history of the child having hydrocephalus, and needing a shunt, that child may be at risk for a subdural at a lower mechanism. That child who has a large head and is known macrocephalic and might have benign extraaxial fluid of infancy. What are the circumstances? What can we document? Is this a child that has always had a large head, or have we seen rapid growth? This kind of information can be added in a complex evaluation to help determine what our certainty is or how concerned we are for abuse at this time. We have to remember that short falls are common in childhood. Children do fall downstairs, but those are also the most common falsified history when we ultimately make a diagnosis of abusive head trauma. And so we really need those details. We need those details obtained ideally from the first people that interact and evaluate the child, as those histories are often accurate, and we can then look for discrepancies in later histories. We should always worry when a child has significant symptoms and no history to explain the injuries we might document, or when this history is inconsistent. As in any medical diagnosis, the history plus a physical examination are the most important steps we as physicians take. We really want to look at the children from head to toe, looking for really very subtle findings, which can really help us to understand the child's risk. Some of the subtle findings that you really need to look hard for and look carefully for are labial or lingual frenulum injuries or ear bruises. Even small ear bruises are very concerning. Bruises about the face or jaw are also highly concerning and may be an indicator of the forces that were applied to the child. Also, when we see young children that have injuries on multiple planes or multiple body regions, this is unexpected from simple household falls or even falls down steps. And there is a body of literature to suggest that when a child falls down the steps, they might have one significant injury, although most children will have minor bruises as their most serious injury. Occasionally we'll see a child with a broken arm or a broken leg, but we don't really see children with a head injury and a broken arm, or a head injury and a liver injury from fall down steps. Recall that a fall down steps is typically a series of small falls, and no single fall has a large force behind it. So too, when we see children that have injuries to their face and proximal arms, their anterior trunk and their posterior trunk, these multiple body surfaces being involved are not really expected from usual child activity and should heighten our concern that this might be something more serious. Depending on your location, there are certain adjunctive assessments that go into helping us make a determination about abusive head trauma as a diagnosis. An ophthalmologic exam, preferably by a pediatric ophthalmologist, but certainly an experienced person in assessments and concerns with abuse, is really important and is a mandatory part of the assessment if intracranial hemorrhage is identified. And in fact, having an ophthalmologic exam absent intracranial findings is much less likely, as retinal hemorrhage are really rarely found in such instances. Imaging is really critical to get firm data as to what our concerns are, and really, as per the AAP guidelines and the American College of Radiology guidelines, if you're concerned about physical abuse and the child is less than 6 months of age, a head CT is really mandatory. Between 6 months to 1 year, it really should be considered, either if there's always if there's neurologic findings, or if we have significant injuries about the head in the soft tissue areas, such as scalp swelling or ear bruises, or any other soft symptoms that might be suggestive of neurologic injury, such as vomiting or fussiness, change in behavior. A skeletal survey is critical and necessary, again, as per the AAP guidelines, in any child who is less than 2 years of age and has a concern for physical abuse. I have some pictures to demonstrate the injuries that we see in abuse, some of the injuries we see most commonly in abusive head injury. This is a CAT scan of a very young infant that shows a small, high, overlying convexity subdural hemorrhage, including tracking into the inner hemispheric fissure, which is really fairly classic. for abusive head trauma. Here's a picture of retinal hemorrhages, which are large and pretty significant in number, although this would not qualify as too numerous to count. And all retinal hemorrhages aren't created equal. There is a differential for the presence of retinal hemorrhages. And if they're small, few in number, and confined to the posterior pole, they may not have the diagnostic certainty or positive predictive value of those which are considered highly concerning and consistent with abusive head trauma. When there are multiple retinal hemorrhages, in particular moving out into the periphery, when they're multi-layered, if there's a presence of retinoschisis, these are all findings which really increase the diagnostic certainty that this is abusive head trauma. Here's a picture of, I'm going to try and use a laser. Let's hope that works. With multiple rib fractures. And this is an oblique chest x-ray because it really just demonstrates the fractures so well. But here's one that you can still see the lucent line but has callus formation. Here's a left callus formation. Here's really a distracted, almost comminuted rib fracture. Here's a rib fracture that has more significant healing and the lucent line is gone. We have additional rib fractures on this side as well. The oblique rib series included in the skeletal survey can be quite helpful in really seeing the rib fractures. Rib fractures, particularly those that are acute, are quite difficult to see in the young infant, which is why we also frequently will do a follow-up skeletal survey when we're concerned about abuse. Even if the original skeletal survey is normal in the young infants, we'll get a follow-up skeletal survey in about 10 days to 2 weeks to look for signs of healing for the subtle rib fractures which we might have missed on initial evaluation. Anyone who pays attention to the media might believe that abusive head trauma as a diagnosis is a controversial medical topic. There's really not any data to suggest that it is a true controversy in the medical community. I think all of us can agree that striking a child in the head or shaking them can be dangerous to their health. Many folks have raised hypotheses for alternative explanations. In particular, physicians who are spending a lot of time doing work in the court system have raised the concern that these are not injuries to a child, but maybe the subdural is due to hypoxia or some other forceful coughing or some other proposed mechanism. These explanations have not been validated, and although frequently accepted in the mainstream media as fact, they really have not been proven within the medical literature in an evidence-based manner that's reliable. Unfortunately, in today's world, all opinions are equal on social media, and a physician who has spent hours and decades of their life studying this issue, both either in the research realm or clinically caring for these kids, their opinion might be dealt with equally from a movie star or someone else that has decided they have an opinion. And in this, related to the controversy of abusive head trauma, which again is not truly a medical controversy, there's a lot of similarities with what has happened in the media with the vaccine concerns, where we really spent quite a long time having to deal with families that didn't want children vaccinated because of the concern for autism, despite the fact that there's no studies that really have demonstrated it being related. And there's really a lot of crossover to that sort of perception in the media or in the general public about the presence of these issues versus what is really felt to be true medically. It's important for us as pediatricians to remember that the legal representation does not necessarily reflect medical community's opinion. And we need to be cautious when we're questioned about these topics. I did want to present a case to illustrate some of this information. And then we'll open up to questions at that time, and then if there's still interest and time, there's a second case that we can do. So it is important to remember that subtle findings can be very significant. It's a 9-week-old infant who presented, mom noted that the eyes were swollen and red when she returned from the store. The baby had had a normal delivery and was full term. While the mom was at the store, the child was in the care of the father. The parents are married in an intact home, kind of a very traditional family. The physical exam, this child presented quite late at night to the emergency department. And the child was felt to be well appearing in the mom's arms. The mom was nurturing and the father remained present. A soft swelling of the scalp was noted. And the infant had good tone, a strong soft symmetric moral, and followed the face at least to 45 degrees. It was noted at the time of the evaluation that there was a very subtle reddish purple mark below the ear on the neck. And on the opposite side, there was also this very subtle reddish purple non-blanching lesion below the ear, kind of near the skull, maybe near the mastoid, and some other tiny, tiny red marks on the neck or jawline. The eye demonstrated this subconjunctival hemorrhage and really some periorbital erythema, not definitively noted to be bruising, with some fullness in the eyelid. Because the physician was concerned for abuse based on the skin findings as well as the soft tissue swelling, a CT was obtained demonstrating the soft tissue swelling of the scalp as well as this somewhat comminuted, minimally depressed skull fracture. And I apologize for the quality of this. This was long enough ago that there wasn't digital imaging. And this is a photograph of an old-fashioned black and white CAT scan held up on a view box. So here we have interhemispheric small subdural hemorrhage in the high convexity. And 3D reconstruction of the CT demonstrates this fracture line. An ophthalmologist was involved and there were no retinal hemorrhages. Skeletal survey was done and there was, the only finding was the skull fracture. Because the baby's very young age and at the time at which this case actually occurred, a bone scan, a nuclear bone scan was also done, which also was negative for any additional areas of bony concern. From this child, there was no history of trauma. Laboratory evaluation was obtained and was not supportive of coagulopathy or blood dyscrasia. There is bruises in a pre-cruiser, a subdural hemorrhage, and a fracture, but no additional findings by the consultant during this skeletal survey. Yet this is non-accidental head injury. And upon evaluation or interview by law enforcement, eventually the father confessed to squeezing the neck and shaking a little. So we can at this point either take questions or do the additional case.
Hi, Dr. McCans. Why don't you go ahead to the second case? Thank you.
Okay. All right. So an additional case. Child presents with a limp. 11-month-old female who is not weight-bearing in her usual fashion, although she had begun to cruise. The concern was first noticed after she was playing in a jumper, like the Johnny jump-ups that go in the hold it on a door jamb and the child can jump up and down. The limp was really decreased weight-bearing on one side, and again, this baby had been pulling to a stand for several months. So I want you to ask yourself what you think about that presentation. So this child presented to a hospital emergency department. And really the only thing that was considered at that time was hip dysplasia. When I reviewed this case later, I thought, well, you have a child who's limping. We should think about toxic synovitis. Could this be, the first manifestation of HSP? Could there have been a trauma? Is there septic joint? At the time, the child had no fever. The outside hospital evaluation was that the onset was after playing in a jumper. Their physical exam was asymmetric weight bearing, no specific area of tenderness, and they didn't see any skin findings. And because they were concerned about hip dysplasia, they obtained radiographs of the hip. I'd like you to think about what studies you might like if this were your patient. So these are the hip films. I want to give you a moment to look at this yourself and think about whether you think this is consistent with the diagnosis of hip dysplasia, or are there any concerns for you on the x-ray. I believe I have another view. And here is the other view. And again, look at it and see what you think. But if you know, the hips really, in both views, really are fine in appearance. Now, coming down here on the right fibula, there's a buccal fracture, non-displaced. I think that kind of injury potentially could occur from these jumping toys that I guess aren't really developmentally appropriate. And here on the left, there is a similar buccal fracture of the left femur. So this is an 11-month-old child who, for the history, is not has asymmetric weight bearing that's new, and yet she has bilateral fractures. A month later, the child presents actually to the same ER she initially presented to in her father's arms in extremis. The father was called by the babysitter because the baby was not breathing right. She noticed this after the child was napping for a while. She related that she found the child asleep on the floor and moved her to the couch an hour to 2 hours before the onset of funny breathing. The babysitting setup was that the father worked late shifts and the mom would take the child to the babysitter and the father would go home from work and sleep for a while and then would pick up the child. Their home was quite close to the babysitter's home. So he ran to the babysitter's. The mom says that the child was well last night. She didn't notice any problems. And I guess actually on that day the father had dropped the child off and hadn't noted any problems. The child was quite well. Because the baby was quite ill, a head CT was obtained. And you can see that there are skull fractures. And this subdural hemorrhage. There's also loss of gray-white matter when you compare the left and right. And there does also seem to be maybe some midline shift. Here is the 3D reconstruction showing the large parietal skull fracture. Skeletal survey, again, the skull view shows the skull fracture. There is periosteal new bone formation along the left femur. There's concern for a classic metaphyseal lesion of the left femur. There is the periosteal new bone formation in the right tibia as well as the injury to the right fibula. And there is a healed or healing with significant callus formation fracture of the second metacarpal on the right. So this case really identifies a child that presented a month before and had the skeletal findings been noted and recognized at that time, we maybe would have prevented what was wound up being a very significant neurologic injury. She did survive and did quite well in her parents' care ultimately, but was going to have long-term physical limitations as a result of her brain injury. And this was a case that those initial x-rays, those subtle buccal fractures were missed both by the treating physician and the radiologist. And in my discussion of the case, I really felt that, had we just recognized that, those fractures, we maybe would have gotten a skeletal survey since there were two. Maybe we would have found some of the other injuries, and we really could have been definitive about abuse given the multiple number of fractures prior to the child sustaining the brain injury. So, again, it really illustrates the need to consider the possibility of abusive head trauma or child abuse in general in children who may even seem at first glance to be a plausible injury, because I would have probably considered it plausible to have a single buccal fracture using one of those jumping toys, but not so much bilateral. So I found it to be a quite interesting case for that reason, and it also demonstrates the need to think about our medical decision making. I really don't in the ER consider hip dysplasia in children that have already started to successfully weight bear. And so that was a significant change for this child, again, demonstrating the fact that this maybe could have been thought through a little differently and saved the child the neurologically significant injury. So that's what I have for today, and I appreciate everybody's patience. This is really a new format for me, so I hope it was beneficial to you all, and I'm happy to now take any questions and answer them to the best of my ability.
Thank you, Dr. McCans.